So thank you so much for this invitation. It's not easy to replace Eugenio. I've been called Eugenia since yesterday, but it's okay. I will try and do my best to review and come to the key points. So, the natural history has changed. We know this, and we know it has changed basically not because of real drugs, meaning the discovery of the resolving medicine, but because of the standards of care, steroids, and cardiac treatment. And this, as we know, has shifted the loss of ambulation, the loss of upper limb function, respiratory and cardiac problems, and patients are getting older and older. So the problems, or at least the issues that we have, are that we are now facing with Duchenne muscular dystrophy boys who are late survivors, and this means that we have to face new issues like psychosocial, mental, behavioral, or anyway, CNS problems, independence, autonomy, life on their own, and different issues which we were not used to face years ago. And we are now facing also problems with long-term effects of glucocorticoids, which we all know are not not minor, but very important to be on steroid. We need to have a diagnosis because the drugs that are coming out and that are there already need to be started early. And we are now facing families giving new treatment options. And so now that we have a diagnosis of Duchenne, it's still a burden, but we at least have more and more things that we can talk about to kids and parents. And so why are we again talking about standards of care? And what's new about them? And as we have heard, the implementation challenges. So 3 articles just came out, and they are reviewing the basic parts of what should be the correct management of a Duchenne boy and his family. And it's divided in 3 parts, and it's basically facing all the aspects of what should be care in a neuromuscular patient, and it's targeted for Duchenne. The topics are basically the same, but updated. 8 of them are the same, and there are 3 new topics which are very important and which underline what's changing. And so we have primary care and emergency, which I still think is a major issue in all countries, because when a patient goes to an emergency department, we all know the difficulties that there are in dealing with the troubles there. We have endocrine management because they get older and because of the steroids. And we have transitions of care. Now we have many patients getting over their teens, and there's problems there or issues that need to be faced and addressed. And then there's adults having problems like in the adult life. And so there's a number of things that can be and need to be addressed. So these guidelines were really not evidence-based medicine guidelines, but they are still very important and need to be referred to because they come from expert opinion. And this means from clinicians, patients and families, and experts who have been seeing lots and lots of Duchenne patients. And this makes a difference in giving directions without having seen the patients. And this is just to give, I won't go into the details of the care considerations because you can all have access to the papers, but I just wanted to outline the structure and give you the main points of what's in there. So all the topics are there. You can see it on your left. And it's divided as to what should be done according to the stages of the disease. So if you see it on the top rows, you have stage 1 at the diagnosis, then you have the early ambulatory, etc., which gives you the ideas to how things change and how things need to be addressed and how the timeline of the exams changes according to the level and the degree and how far the disease has gone. So there's a a very detailed diagnostic flowchart that can be followed and needs to be followed because, as we have heard initially, there is still too much of a diagnostic time lag, which is getting shorter, but still needs to be faced. And there are still controversial cases where you get controversial results from the genetics and the biopsies, and there needs to be a flowchart that needs to tell you what to do and how to do it and when to do it. And there's a number of symptoms that need to be considered, especially for clinicians who are not so familiar with Duchenne, who maybe just concentrate on the motor problems. There's a number of non-motor problems which are very important, which may be the presenting symptoms in Duchenne. And there's a whole list there that is very important and needs to be focused very with attention. The rehabilitation assessments, there's going to be a review on these and the interventions. And this was already addressed previously. There's a bit more details here on how and when to do it and the timeline. So it's important to go through the reassessments every 6 months, and there's no point in waiting to see the problems there. Even when the kids are not yet having problems, there needs to be assessments and monitoring regularly. We are having all our kids, hopefully, on steroids, and this means that we need to know how to deal with the problems, especially because we are saying that they are going to be on steroids for a long time. We know that even when they lose ambulation, there's evidence that it's better if they stay on steroids. So this is giving problems with the adrenal insufficiency, with the weight, of course, with the bone. And there's also a need for some instances to reduce the steroids because of problems, because of other issues. And there's even guidelines, as there were previously, but it's captured again, as to what to do when there are different situations, and it's very practical. There's 3 examples there to know how to taper and deal with the steroids. And what about puberty and delayed growth? And so there's references there. I won't go into the details. There's going to be topics on this, but just to give you an idea of how the thing is structured and how you can have all the referrals for very practical issues that can be dealt with. And for the delayed puberty, there are now very precise indications that there needs to be a referral to an endocrinologist if there is a delayed puberty development by age 14. So we still see kids in their adolescent age who do not have a referral for endocrinology. So this has not been a major issue for years, and now it's really important that we are focused and regularly paying attention to this. And testosterone replacement therapy, again, is one thing that is recommended. So I'm sure there's going to be talks on this and going into it, but these are important issues that need to be taken into consideration. GI problems are one thing we were actually discussing even yesterday as a talk like between us, and it's underestimated. And we really need to pay attention. There's both initially overweight, but there's gradual loss of weight, which just occurs without us really paying attention because there's a reduction of the intake of food because the patients get weaker. They tend to fatigue easily, and we are not conscious as to how much weight they are continuously losing. So again, this needs to be regularly assessed, and at every visit, this should be considered and talked it over with the kids and their families, because it may not be an issue. So they may not come up with it, and we really need to ask and go into it, and there's indications as to what to do and when to do it. So obviously the respiratory and the cardiac have for years played the role because they are the major issues of morbidity and mortality. And there's again indications, and this is a confirmation, that we need to think of increasing the volumes when there's of the lungs when there is an FVC of 60% and start there. And lung recruitment is important, and we may have a sort of a fear to talk about it with the parents and the kids, but when they feel the improvement and they see how they can actually get it done and feel better, they can start on their own and use the machines and get the feeling that they are doing better. So not only lung recruitment, but cough. Cough, as we know, the secretions, again, this is a confirmation, it's a must that has to be taken into consideration, and especially when we know there's infection or other things, but there needs to be a regular training and regular attention as to the implementation of this. And there's different rules in different countries as to the prescription of the cough machines, but no matter who can prescribe it, it needs to be implemented when it's necessary, and it needs to be there even for issues that may not be there at that moment, but which can come up when it's the time. Non-invasive ventilation is something we would not like to talk about, but we need to talk about it because it's very important. It has prolonged the life. It can be very useful for patients, even subjectively. They feel much better. And there's different, of course, it's difficult keeping it, the face, the masks, the face problems, the skin problems, but there's ways that with lots of education, lots of teaching, lots of talking it over, that can be overcome, and there's a solution that can be found tailored for each patient. And it's very important. And there's issues there, not as to when to initiate, because there are precise indications there. And there's most consensus there, I would say there's no discussion, that there's the use of NIV in most clinical situations. It's not common to have a patient with Duchenne going into a tracheo as happens with other diseases. So the non-invasive ventilation is, and especially at night, is the good thing to do for most patients. Cardiac monitoring, of course, is the other one, which is very important. And there needs to be again, there's a flow chart for when to do it and what tests to be done. And again, there's no need to wait for the symptoms. We all know that the Duchenne boys do not have the typical cardiac symptoms of an insufficiency as other patients. They move less, they get fatigued less than others with exercise, meaning that they can't do the exercise as others, but they do have symptoms which need to be taken in consideration because they are suggestive of cardiac problems, like loss of weight. There may be nausea, there may be fatigue and other symptoms which are not immediately directly related to cardiac if one doesn't consider it's a different situation here. So there's again a list of things that need to be taken into consideration in different situations for the ambulatory and non-ambulatory stage. And if there's a situation of stress or typical conditions like surgery, then there's a must both for respiratory and for cardiac. Bone health has been one of the themes in the revision of the standards of care, which has had some differences, basically because there is now a new attitude that it's not just the BMD Z-scores that we have to look at, but we need to pay attention to the idea that there may be frequent manifestations of osteoporosis even without having an apparent fall, an apparent pain due to a bone problem, and they can be relatively asymptomatic. And one also thing that has been pointed out in this new review is that there can be, if you have a bone fracture, even in a asymptomatic kid, this may be to the beginning of a potential cascade of small fractures. So it has to be taken as an alert, and that can be prevented and taken care of with the implementation of the standards of care for the bone. So this is no longer focused on bone mineral density, but the BMD serves as an adjuvant in an approach that can identify the initial signs of bone frigidity. So this is something which looks the same, but it's not the same, because it means that you have to pay attention, even without symptoms, regularly for kids when you get to see them. And there's a precise treatment algorithm which tells you when to start and what to start and how to deal with it. So it's there. So the timing of the treatment initiation is what I wanted to point out as the notable difference in these standards of care now. And this is something that can be done regularly. It doesn't need to have a specialized clinic, but a guidance on fracture prevention is something which looks obvious, but it's very important that we consider it and go through it with the kids and the parents, and it can be of great help. And there's a whole list of things that can be easily adopted and implemented and make a difference. Orthopedic and surgical care, that's another issue. And again, this has been an issue and is an issue because it's not easy to talk about surgery and orthopedic surgery in these kids. But again, when to do it and what to take into consideration is there, and it's very clear that it needs a multidisciplinary approach. It doesn't have to be something that needs to be left to the orthopedic alone. It needs to be assessed in a multidisciplinary way and discussed kid by kid, specifically for each kid. And when we need to face surgery in a DMD, like in other neuromuscular disorders, but in a DMD patient, there needs to be consideration as on problems that may occur and that may have a difficulty in being overcome if we have not thought about them before. So these are usual things that are considered before surgery, but there needs to be a more alert with a DMD patient, because if you go into a surgery room and the surgeons, they may be so used to surgeries, they may not think that there needs to be such an alert. And instead, we know, because we know these kids and these young adults, that even though they look like they're apparently stable, even maybe respiratory-wise or whatever, they need to be looked at with special attention and care. And so this is why I still wanted to bring it out here, because we know it, surgeons know that a Duchenne needs to be treated differently, but still there is not that sufficient alertness for the whole team to be there and be ready when there's a surgery to be done. And these are the three main points that are different in these new standards of care. And these are some things that can be done by the primary care physicians, and it's very important, and they do make a difference. Immunization, first of all. In different countries, there may be different indications, but it's important that immunization is done and is timely considered. Nutrition we've talked about, but this needs to be revised, and this can be done regularly by the primary care. Dental care is another big problem. It can give infections, it can give pain. It's difficult to find somebody who can treat the dental problems because of the difficulty patients may have opening their mouth, the respiratory problems, the compliance to this. It's for all kids, for young adults, but here it's even more. And it needs to be done regularly and timely before it's there with too much pain or too much difficulty, and then it becomes something that needs to be done without discussion, and it may be too abrupt for the kids or the young adults, so it needs to be regularly assessed. Safety counseling, we've talked about falls, which is something which is very important, and again, try to bring the multidisciplinary team together, and this can be a role that the primary care can have and can try and create liaison and alliances with specialists who may not be specialized in Duchenne, but who can get there if we try to educate them and to go maybe with the kid or the young adult and talk to them and allocate lots of time for education. And then you can get something from the other physicians who may not be experts, but it needs lots of time, but it can be done and it must be done, and that really makes a difference. Monitoring for adrenal insufficiency, again, that's something, and there's symptoms there and hints that can be thought of that are maybe not routinely asked during a clinic visit, and that needs to be considered and can be faced, and there's treatments there, and there's lots of problems that can be avoided. And psychosocial care for patients, and let's not forget families. Mothers and fathers need help, and we need to talk and allocate time for them. This is something that a primary care physician needs to think, and we need to consider it and create a good team with the specialists and the others. And the other screenings, these patients can have other problems, and we just need to focus on these others and help the other physicians think that it's not only Duchenne, there may be other problems. And emergency care, there needs to be first of all, the patients themselves and the family need to be very aware as to what to do and what not to do. And we all know about oxygen, and this needs to be very clear and discussed, and there's advanced directives that need to be discussed, of course, timely when it's the moment, but not when it's too far on. But we need to make sure that we are doing what the patients and their families want, and this needs to be faced with courage and with convincement that we are doing the right thing, and we're trying to fight and do as best as we can, but there's times when we need to talk about these things, and we need to face it properly and timely with the families and their patients. Breathing problems need to be written down in the alert cards with these patients must have, and there are alert cards existing in the Duchenne community, and which need to be implemented. Each country or each patient then can sort of maybe adapt it to itself, but there are guidelines as to what needs to be done and what needs to be taken care of when there's an emergency. Cardiac symptoms, we need to ask about them if there's an emergency, if there's something not going on, which is very clear because we know that they are not the typical cardiac symptoms that we may expect. Again, endocrine problems. It may be that there's stress steroid dosing may be necessary when there are problems that require more stress for the patient, and that may cause a problem to the adrenal glands. And so there needs to be attention as to what can be done, and just bear in mind this list of problems that may not be apparent when there's an emergency. And these are the main problems of emergency that usually we are faced with a patient having a sort of a general malaise, or a more specific, if there's a fall, that's easier. But if there's a general malaise, these are the things we need to think about, and these are the things that need to be brought to the attention of the emergency room. And the psychosocial care is coming up more and more as we have older boys and older families. So there's more and more burden, and there's psychological problems that are coming out, and also needs that these patients have. And we know about the dystrophin in the brain, so there needs to be a sort of checklist of things that can be looked at to make sure that it's nothing to do with dystrophin. It may be something as a reaction of the patients, or it may be related to the disease. And so there's consideration that has to be given to the eventual mental problems, which may be fatigue, tiredness, difficulty of attention, some language problems, some communication problems, and some behavioral problems. And there needs to be an attention as to focus on what is really there and why is it there. And some things can be dealt with, again, with education, with knowledge. We are used to hearing it's the dystrophic, it's the muscle problem. It may not be the muscle problem, it may be the brain problem. So there needs to be a consciousness as to brain and muscle need to work together, and there are things that can be done to improve the management of these patients, make them feel better, and do something for them and their families. And for instance, here there's a whole list of items that can be used to test, but that's testing, and it's not there just for academic reasons. It's there because it gives you an idea as to where the problems are, if it's more cognition, if it's more behavior, if it's more dystrophin, if it's more reaction. So they are there for helping to understand your patients and their families. And there are pharmacological interventions which can be used in these patients. It's not that a Duchenne boy is not allowed to have any other medication. It can be used if it's necessary, and it needs to be considered in the respiratory and the cardiac problems. And so again, it needs to be tailored. There's no rule there. It needs to be considered case by case basis. And again, there's a flow chart dividing it according to the stages of the disease, which makes it easier for us when we need to access to these cares, because then if we have a bunch of indications, it's hard to move in them. Whereas here, I think it's very well done it's divided according to the stage of the disease, and it's helpful for us to move and to use them and to apply them and to try to do as best as we can with what we can and with what we have at our site and what we can improve and implement. Some things basically based on education and on time allocated there can make a difference. And there's most of the interventions here are education-wise, and they are time allocated again for listening and for talking. And I think this is treatment. And I think this is very important, and I think that we can all do this, and we can all sort of push our colleagues and physicians to try and be in the team and find time to do this. It's not, of course, basically for the people in this room who, if we are all here, it's because we already do this, but it's for, try to implement others and try to get them all on board. And young adulthood is very challenging, and there's lots of things that we've been learning, at least I have been learning with these kids growing into the transition and getting bigger and older. And housing. They want to, not many of them, but quite a sufficient group are asking for implementations in their homes and trying to be able to move on their own. They want to move faster and independently. They don't want their mothers and fathers there moving them around. There's a problem with healthcare. I don't know, I suppose it's different in the different countries, but there's this dreadful cutoff of 14 or 16 or 18 where you lose your doctor. And so there's a transition problem as to you get for years to go with your doctor, and you get into contact with him, you know him, you tell him things, and then there's a transition phase where you get older, and the older doctor, the neurologist, maybe don't have the same type of training, and they don't know you because you are there as a new patient, and there may be difficulties there. So we need to really try to think and work on this transition phase and try to create the connection with the adult neurologist, if possible, earlier, and get them into the pathway, not when it's the cutoff age, but before, and so that we get into contact with them and try to get them in the problems and get the patients and their families with these other doctors, or at least keep working together. And activities for daily living, there's a whole bunch of associations and people who are there to be able to provide independence activities and services. I know it's different in the different countries, but I am sure that in each country there is at least part of this, and that maybe it's not that well implemented and well known, and not so many patients and families have access to these services, so we really need to push on that. Education or employment, we need to start thinking that these young patients become adults and they need to work or need to get into this world of grown-ups and of independence, and it's hard. It's hard for people who have no motor problems, but we still need to think that they feel it, and we need to be able to address this and try to think that it's not something exceptional that they are talking about. It's something that's not one of a priority. It's there, and we need to think about that. And relationship with others. Sex and intimacy, these are coming up problems, and I've been learning a lot from them, and you need to get into a very good relationship with these patients before you can address these. And of course, again, the famous cutoff of 14, 16, 18, it just can't be that you can switch from one thing to another and start talking about these things. You need to really build the relationship, and this is why I think this is a good point that has come up in these recommendations here, that needs to be really faced early. So I just thought I would bring an experience that we have had with, we have this association in Italy, which is there for people with disability. And it's there especially to create possibilities for teenagers and young adults with muscular disabilities who want to or look for their independence. And so this was a quick extrapolation from the first years of 2018. And 31 patients with DMD and Becker applied to this service in Italy. This is in the north of Italy. And 6 between 14 and 18 years, 25 over 18 with a mean age of about 30. The oldest one is around 43 years of age. And the reason why they've applied is because they want to live on their own, or because they want to have a personal attendant. They don't want their mothers and fathers there. And they are seeking for jobs. Now, this is not a good number. Only 10% of DMD are working right now. And from these numbers, we are aiming to have it higher. Most Becker patients are working. None of the Duchenne that we have are married or have a family life, meaning on their own. So these are numbers which we would like to see higher and better. But again, this is something, not all patients know about these services. Not all families know about these services or want to address these services. But I think that we really have to consider this. So I thought I would give you this hint that I thought was interesting. So the challenges with implementation, I thought that I would sum it up like this. Challenge number 1 is we have improved with the diagnostic process, but there are still patients who have a delay in their diagnosis. It's fortunately rare, but we still do see some patients who get their diagnosis at 10. Very few in Italy, at least in northern in Italy as a whole. But there are patients who may get a late diagnosis. And the earlier the better, both for rehab and for pharma. Rehab, because even before patients maybe get an upper limb, for instance, motor function problem, they may still have fracture problems and spatial abilities that can be improved, that are related to their cognition rather than their motor function, and that may start earlier than their motor function disability. So if we are aware of that and we have an early diagnosis, we can get into implementation of rehab, for instance, of their apraxias and visual problems, visual spatial problems, and get improvement, which may not be necessarily parallel to their motor function rehab. So the early treatment is something that requires an early diagnosis. Challenge number 2 is that we need to implement these standards of care. I know this is obvious, but it's not obvious if we think that if we really read into these standards of care and we look at the timeline as to when the tests need to be done, as to how many things do we need to ask these patients and look at, not everybody gets the same attention. And so it's important for patients, because if they are aware of these standards of care, and I am very happy to hear that we are allowing with these educational leaflets and training and all these meetings, that the patients themselves get there, they are very proactive, and so they need to be it. And this allows them to have a better care. And it's important for physicians because the cares are there, the recommendations are there. And so if we have doubts or we don't know how to maybe do the best thing, there's guidelines there, there's indications at least, not guidelines. And it's easier for us to move and to access to them. And so we can provide information for other physicians. And it's important for clinical trials. Why? Because if we do not get the patients all at the same level of standards of care, we will never understand whether a drug is actually working because these patients are not applying their standards of care, or because the drug is not working. So it's really important for many reasons which look obvious, but if we really think about them, we really need to consider them. And challenge number 3, the recommendations are there, but not all patients get access to treatment as indicated. So this was a relatively old paper now, but important. I mean, it's only 4 years ago, and things are improving, but we really need to get there. Some cardiologists who are not expert in the field are maybe reluctant to start the treatments without overt symptoms or without having very good knowledge about the disease, because they have maybe never seen a patient. And so I think that this is something we do not have to underestimate yet. So the take-home messages for me are that the care recommendations are there, they are available, and so there's basically no excuse that we do not really apply to them. I know it's hard. There's not only sort of a voluntary will or unwill to apply them. There may be practical, budget, logistic problems, but I'm quite sure that all of us can still improve and get them better. It takes a multidisciplinary team for all that we've heard. And there needs to be a tailored program, and there needs to be lots and lots of education and time allocated there with the different specialists to get an individualized care program. And we really have to think that drugs today and tomorrow will not be the solution, but they will be add-ons to this pathway of care that we are all doing and that we need to improve and keep going. And so I thank you from Rome, Eugenio, and from Milan, Eugenia, Valeria. Thank you.
Thank you, Frank.